So first of all, what does a good service look like? And I think when you start this work, working with adults with Down syndrome who are at risk of dementia, then people spend an awful long time thinking about the assessment and diagnosis and those processes. And I've seen all over the UK and other places where I've been asked that such a lot of focus goes on the assessment procedures. They forget what happens next. And I think what happens in services and systems is that you go through a process of development, of your own development. So you have to obviously learn how to do the assessments and to get the right diagnosis for people. But once you've got that under your belt, and that can take several years for people to feel comfortable with, then people begin to think about, okay, how do I then support and care for people with Down syndrome, for their families, for their peers? What can I do about the interventions? And then the thinking has just moved on, and our thinking, certainly where I work, has moved on now to beginning to think about, okay, that's fine, we've got that sussed, we think, on a good day, but how do I know that we're doing good? How do I measure the outcomes of what we do? And I think that's the process most service systems go through. So again, it'll be interesting when we have a discussion later to think about where your service systems are in that process. So this isn't just about assessment and diagnosis. Again, a lot of the work that I'm going to talk to you about is summarised in this national guidance in the UK that was jointly written between myself as chair of the British Psychological Society Working Group and the Royal College of Psychiatrists. And if anyone wants a copy, my email is on the back of the handout. Just email me and I'll whiz that over when I get back to the UK. Interestingly, the whole idea of that whole system approach has been around for quite a long time. So McCarran, back in 1999, identified what he thought was the really good requisites of good care for people with Down syndrome and dementia. And again, some of those things we talked about yesterday. So one of them, and I think one of the most important ones, is that developing that shared vision. What are we trying to achieve here? What do we want to happen for people with Down syndrome at risk of dementia? So we can build that shared practice, that shared vision. Because if you don't have that solid foundation, if you don't have that shared vision across all the services in the local area, across all the providers, across the commissioners, then the values, the expectations, the approaches, and therefore what the person actually receives will be different amongst different people. And what we're trying to get is continuity and consistency and good and excellent care. And if you don't have that, then that generates conflict and frustration between different providers. So you might have a day service provider trying to do one thing, and a home provider trying to do something else, and a family trying to do something else. And if you haven't got that idea of where are we going collectively, and if you don't resolve that, then that's going to place unnecessary demands on somebody who's already confused, the person with dementia. So if you're all acting slightly differently, if your expectations of the person are all different, then ultimately it's going to impact on the person. So for me, we need really good, effective management and leadership and commitment to making the changes to provide excellence in dementia. And that's why I was so pleased to be invited here to Vancouver, to the Down Syndrome Research Foundation, because clearly you have a commitment to do that, and that's really, really good to see. So the first area I want to talk about is capable staff support. Staff, apart from the families, obviously, but staff are our greatest resource. And we need to nurture staff, we need to care for staff, we need to value staff, we need to educate staff, and we need to hang on to the good ones. And that is really difficult, certainly over where I work in the UK, and I'm sure it's probably no different here in wherever you're from. So we really need to think about how do we develop our workforce, how do we evaluate our workforce so that they are ready and able to deliver really good dementia care for people that we're supporting. Is there rolling programs of dementia training provided in the identified area throughout the year? Are homes caring for people with Down syndrome and dementia specifically targeted? is there a consistency in what the training delivers? So again, you could have a different sort of training being delivered in your daycare to being delivered in your homes. Again, if the approach isn't the same, then that will result in confusion. One of the things that I've really become clear to me over the 20 years that I've been doing this work is that, on the whole, bringing individual staff members out to a course on dementia doesn't change practice. And I say that with a heavy heart, because for 18 of those 20 years I've been delivering that sort of training. But what I suppose a couple of years ago, I suddenly realised that I was getting staff from the same organisations coming to the training, and I'd say, okay, have you had dementia training? Oh yes, we've had dementia training. What have you learnt? Well, not a lot. How's that impacted on what you do? Not a lot. So why are we still getting the same staff coming from the same organisation where that learning hasn't been shared? They've paid for the staff to come, they've released them, so that means they've covered it with somebody else, and yet somehow that doesn't go back and change practice. And so what I think needs to happen, and I don't know how it's organised here in Vancouver or in where you come from, is that the only effective way of training staff is team training. It's getting the team that actually working with the person, around the person together, to think about, to work together, to hear the same message at the same time, and to think about what they're going to do differently. Does that make sense? It isn't easy to organise, because obviously trying to get the whole staff team together. The other issue about that is it must involve the manager. So the manager has to be there as part of that training. They cannot abdicate their responsibility for making sure this will happen. And I've certainly had team training where the manager is clearly not on the same page as their staff, and the staff are really committed, and the manager's going, oh, it's too difficult. Oh, no, we couldn't do that. Oh. And you just think, this is a waste of time. We are never going to change what happens for the person while we haven't got the whole total commitment of the whole staff team and the manager to change things. Where it works brilliantly is when you do have a manager who really wants it to succeed and actually just embodies everything you've said. So I can think of one particular service that I worked with where I came and did a whole day with a very small staff team supporting a really interesting man with dementia. And they just took it and ran with it. And now when I go in and a member of staff isn't quite doing, they go, remember what Karen said? I don't mind them blaming me for what Karen said, but you know, they know exactly what to do and how to deliver it. So we really need to think about what needs to be achieved through training. It's about change in practice. It's about competence. It's about expertise. And it's about confidence to do the right thing. And giving people that time and space to get the right value base, to get the right understanding, and to be able to support the person best. And what we've done is try to suggest training, support and outcomes for each stage of dementia. So in the guidance, which again I can send you in your handout, which you probably can't read because it's too small, what we've done is try to think about what sorts of training, what would be the content of training at each of the stages of dementia, what is the ongoing support that you'd be looking for? Is this working? Oh yeah. And then what's the outcome required? And that's really important because it is about what we're going to do with this. What are we trying to achieve? So at pre-diagnosis, and maybe you've got people who are at an age where they may be at risk of developing dementia. You want your staff team to be prepared for that for the future. Then you'd be looking at things like the signs and symptoms of dementia. So what would you look for? What do you think? What would you make you think, I'm concerned about this person? What would you do about that? The whole diagnostic process and how to make a referral. So again, that will be different in different areas. The importance, as we talked about yesterday, of starting life story work before the person ever develops dementia. It's no good waiting for the person to develop dementia to start doing the work with them, because by then their short-term memory is already compromised. Their ability to move information from their short-term memory into their long-term memories we talked about yesterday. So this is something that can start, well, should start in childhood really, But if you haven't already got a life story book for your people that you're supporting, this is a really good time to start to do that work, to involve families, to involve their friends, and to involve the person to think about what's important to them. And to make sure that all their care plans, their health action plans, their communication passport, their end-of-life plans are already being in place and discussed and thinking about the future for people. So if that's what you're training people, then what they will get from that is an ability to understand what happens in the diagnostic process. They'll be able to work with the person to develop their life story work and have those difficult conversations, and I'm not saying it's easy, about end of life. But again, mostly, in my experience, it's our inability to talk about those things that causes the problem. It's our inability to use the word dying or death, rather than the person with Down syndrome. Most people with Down syndrome are fairly matter-of-fact about it, in fact. But we need to start having those conversations about what would you like. And the outcome will be that then the person will be supported if they need to go through the diagnostic process well. We'll know what other health issues are identified, could be identified and need to be treated. We'll know about their social life and their social issues, and we'll have all those plans in place ready to be used if necessary. Once we have got someone who's diagnosed, then I think the issues that we need to look at training are these. So one of them is about the model of dementia, and I'll just do a quick recap because I will refer to that quite a lot today for the people who weren't in the room yesterday. So it's in a little book called The Simplicity of Dementia by Buijsen, who's a Dutch clinical psychologist, psychogerontologist, and his father had Alzheimer's disease. It isn't a book written about people with learning disabilities, but it's very transferable. And what he says is that Alzheimer's disease is a very simple disease to understand if you understand the 2 laws of dementia. And the first law, who can tell me what the first law was? Who was here yesterday? Remember? No one's going to admit. The law of disturbed encoding? Yes? So that says that basically our short-term memories only hold our memories for 20 to 30 seconds, and that if we haven't encoded it into our long-term memory in that 20 to 30 seconds, then it disappears. And once Alzheimer's starts, that ability to move information, to encode from your short-term memory into your long-term memory becomes disrupted and eventually becomes very difficult and disappears. Okay, so that means that people have difficulty making new long-term memories. But if you remember, we talked about the consequences of disturbing coding. So we talked about people being very anxious and very stressed in new situations because they couldn't understand why they were there, what they were meant to be doing there, because they wouldn't have remembered the instructions. We talked about people asking the same questions repeatedly, not to wind you up, as people always tell me, but because they can't remember they've asked the question, nor can they remember the response. We talked about people losing track of conversation, because again, to have a conversation with someone, you're needing to encode from your long-term memory, short-term memory into your long-term memory. And we talked about people losing their belongings, so they've put something down in a non-familiar place, that's gone, don't know where that was, and those sorts of issues, yeah? And what that must feel like to someone when you know that you're not really taking things in, and that makes people very anxious and very stressed. We then talked about later on, as we move to middle stage dementia, we'll come on to that in a minute, that people's rollback memory, their long-term memory, starts to get affected by the dementia. So in the early stage of dementia, our long-term memories, all those memories we've ever put together are there in our brains, they're intact. But then as the middle stage of dementia starts to come through, the Alzheimer's disease affects the those long-term memories, and they affect them from the newest memory backwards. And that's why it's called rollback memory. So as it affects those newest memories, it's like they've disappeared. And that's why people can tell you about things that happened 20, 30 years ago, but can't tell you what they had for lunch. Yeah? That makes sense? Okay. So, giving their staff That understanding is, for me, one of the most powerful bits of the training. Because rather than then just seeing people as a list of signs and symptoms, what people understand is, oh, that's why that's happening. Oh, that's why they're doing that. And they can begin to relate it to the person with Down syndrome. We give them a philosophy of care, and again, we talked about that in detail yesterday, about stress-free, failure-free, individualised, consistent, and without the time pressures, which all sounds very good when I spell it very quickly. We talked yesterday quite a lot about the physical environment and the importance of adapting the physical environment. And I think throughout the conference, we've heard the importance of pictures and objects of reference to people, rather than relying on verbal information. And we talked a little bit about the beginnings of use of medication. What that gives is staff a really good understanding to accept the diagnosis and the changes, to think about the grief and loss that's going to happen, the grief and the loss of the person that they're supporting, of the person who's maybe quite able now, but will be losing those skills over time. The importance of thinking about how they're going to implement the philosophy of care and how they're going to make sure that there's real consistency of approach, that everyone is doing things in the same way, so as not to add to the confusion the person is already experiencing. And the outcome required is that people at this stage are supported to maintain their current lifestyle, but giving people additional supports and prompts. So this isn't a time to change what you're doing, but it's about just adding a bit more, being a bit more supportive, maybe thinking a bit more about your communication, maybe thinking a bit more about how do you actually go in and support somebody to do their daily living tasks or whatever tasks they need to do. At mid-stage, this is the time when the dementia is the most obvious to people. It's the time when people often get more agitated, more confused, perhaps display behaviours that they might not have displayed previously. So we would train people looking at communication. We would particularly look at this stage as supporting the peers, because it's often at this stage that it's quite difficult for other people to be living with the person. When your friend isn't being as friendly anymore and doing some strange things, we need to make sure that the peers understand what's going on. We need to make sure that people know what a failure-free activity is. And in my experience, staff find that really difficult to think about things that are failure-free. We need to make sure that we also focus on people's health, and particularly the likelihood of people developing epilepsy for the first time as part of the dementia. And we talked again yesterday about the prevalence of that being something between 78 and 98% of people will develop epilepsy for the first time. We talked yesterday a lot about pain recognition and management. And again, it's really important because as the dementia progresses, people lose their somatic experience. They lose their ability to be able to identify where in their body a pain might be. So they know they're in pain, but they might not be able to tell you that which part of their body. And what they might tell you is the last pain they remember, which may be a completely different part of their body to the pain they're actually now experiencing. And Diana Kerr, who's done a lot of work about pain in people with learning disability and dementia and Down syndrome and dementia, tells a horrific story when she does training of a lady who was complaining for many months of a headache, and she'd been through every single investigation under the sun for headaches, including MRI scans and medication and the rest of it. And it wasn't until someone had the bright idea of doing a full body examination that they found an overgrown drawing pin in her foot. But she couldn't tell you, because all she could remember, the last pain word she knew, was headache. So that hopefully then, the sorts of training in this area will help people understand people's behaviours and explore solutions. The importance of avoiding confrontation for people. If somebody thinks today is, well, I'm not even sure what today is because I'm jet lagged. If someone thinks today is Monday, so be it, it's Monday. Because at this stage of dementia, it doesn't matter, okay? If you argue with people, all you'll do is make them increasingly more agitated, more stressed and more confused. You just have to go with the flow. And so you need to help people understand and cope with people's agitation and distress. And hopefully then the person can be supported to live as full a life as possible. It will be a slightly different life as things continue to change, which focuses on the things they like to do best, and again, without any unnecessary changes. This is not a good time to start moving people out of what's familiar unless you can really have to. And then when we get to late and end stage of dementia, the tone of the training really does change at this stage. And for me, it involves many more of the other therapists and other people in our community learning disability team, because it's much more about the physical care of people. So the safe handling and hoisting of people, the safe eating and drinking. And again, yesterday I talked about a happy eating pack, which you're very welcome to come and have a look at. The importance of really good tissue viability, skin and pressure care. The management of failing mobility, falls, posture and positioning. And again, all the equipment that needs to go with that to keep people safe. And of course, meeting people's spiritual needs. And again, I think sometimes at this stage of dementia, it's very easy just to focus on people's physical health needs, but to forget their emotional needs too. And it's a time when we really need to put in really good support for end-of-life care, both for the staff and their support of the people who live with the person and their family, and make sure that we get aids in a really timely manner. And again, I don't know what it's like here in Vancouver, but in particular, we have real issues getting the specialist wheelchairs that we need for people in a timely manner. And often people end up being kept in service, being kept inside for a long time, when they could have had a really good community life because they haven't got a wheelchair that supports them enough, particularly supporting their neck and their head and their seating. So this allows people to receive to continue to experience activities and support that's familiar to them. They can be supported in a dignified and safe manner, and that the end of life care results in what we call a good death, that people get supported to die in the place they want to die in a good way. So I just wanted to talk a little bit about support to family carers, and family carers are hugely important to supporting people with dementia. And I think it depends as well where the person is living, because the needs of the family carer will be different slightly if the person is living with them or if the person is living within some sort of supported placement scheme and they're not doing so much of the hands-on direct care. So I think all the things that we talked about previously about staff will apply equally to family carers if they're the person doing the hands-on support. But even if they're not, they'll still need to know the information about what's happening to people at the different stages of dementia. In my experience, though, the information needs are slightly different because families are different. And some families want to know everything at once, and some families don't want to know at all, and some families want a drip feed of information. So it's about forming that relationship with the family that you're going to be supporting over time and working out with them when they're ready to receive and get information in the right way. I can think of a family I supported for quite a long time who the gentleman had lived in residential care for all his life, but he had a sister who was very involved and her husband and a brother. And it took them until he was really well into middle stage of dementia for them to be able to admit that he did have dementia, because they were looking obviously for every other reason for his change in circumstances, because they didn't want to think that their brother had dementia. And it was only really in the last 3 or 4 months that we've been working with them that they've actually come to me and said, actually, we need some more information about what's going to happen at the end. And that's the first time they were able to come and ask for information and be ready to receive that information. And we did talk that through, and I've sent them loads of stuff, and we'll talk about it again. So it's important to be able to judge when families need information and how they're going to receive that. For some family members, if their person is still living with them at home, particularly if it's a parent, there may be huge codependency issues. So the parent might be an older person and will likely be an older person themselves. If the person with Down syndrome is already developing Alzheimer's disease, they may be having other health issues. They may themselves be suffering from early signs of dementia. and they often in a codependent symbiotic relationship. And it's very important that's recognised and managed well across older people's services and disability services so that people's needs are met. Because it's often when one or other of that part of the system starts to fail, then the whole thing collapses for both parties. And again, you hear some really good stories about how it works really well, and you hear some horrific stories. And again, I took part in a research project many, many years ago called Growing Older with Learning Disabilities, the Gold Programme in the UK. And Dahlia McGrill, who was doing a lot of work around family carer support, tells this horrific story of the mother who was in her 90s, who was supporting her son in his 40s with Down syndrome dementia. And so at 12 o'clock, the support worker from the Older People's Services used to come, get pizza out the fridge, cut it in half, put half in the oven and serve it to the mum. And at 12:30, the support worker from the Disability Services used to come and get the other half of the pizza out the fridge, put it in the oven and serve it to the person with a learning disability. And again, no tied upness, no thinking about the social aspects of eating, just horrific, but those are the sorts of stories you hear. So it's really important to think about the whole system around the person. It's important to think about engagement issues with families. Families are going through other issues, not just related to the person with dementia. So again, you need to be, take care in your approach, take care in what you're talking to people about, take care in hearing their story. I worked with a lady who lived at home with her parents. Dad had vascular dementia as a result of having had a stroke. They'd recently, just before the lady got diagnosed, they'd recently moved into a first floor flat, which was a problem from a house. And Mum was finding it increasingly difficult to accept what was happening to her daughter. And I was going in every couple of weeks to support them. And we'd talk about, how, and she was brilliant at supporting her daughter. She just got it all the way through. And we had one really, really painful session one day where she said to me, Karen, when my daughter was born, she wasn't a typical Down syndrome baby because she didn't have the congenital heart problems. She had the GI problems and her esophagus wasn't attached to her stomach. And so she had an operation with the day she was born and she survived. And, for 47 years I've cared for her. She's been part of our family. She's never been in any form of short breaks or residential care. But if I'd known then what I knew now, I wouldn't have given my consent. And that just floored me. I managed to hold it together till I got back to the car and just, oh my God. But again, that reminded me just how powerful a message it is about talking about Alzheimer's to a mum, to a sister, to anyone, and about what that means to that family. So we really need to be careful about the work that we do with families. We need to involve them in life story work, as we've talked about. We need to make sure that we're offering them the right support services, including short break services, whether that being someone coming into their home to support the person or whether the person going into any sort of short breaks. And we need to be careful about knowing when to help them ask for help. Because again, certainly the families I work with, particularly the older family mothers, are very reticent often to ask for help. They've grown up in a society where it was their job. And, when I say, we can offer you support, we can help you do this, no, it's my role. And you have to recognise that and work with that. But it can be very difficult sitting there thinking, I could make this very different for you if you'd only let me. But you have to wait till they're ready to let you. So again, it's quite difficult work to do. We can provide information for families in individuals or groups. I have to say, although we've supported over 500 families in the last 22 years in Surrey, we rarely end up running groups. It's very difficult to find families who are at the same stage at the same time who want the same information. So although we've offered group sessions, actually on the whole I don't think it works. So most of the work we do is individualised to the family. And we bring information as we need to. We've got our own information pack that we use within our service. So we have about 40 leaflets that we can use flexibly with people, just giving them information as they need it. So it's tailored to the needs of the people. But these are, and I've got some of the packs with me. So these are some of the professionally produced information that we tend to use a lot. So the Down Syndrome and Dementia Resource Pack. This Down Syndrome and Dementia Workbook is really quite a nice tool for staff, because what it acts as both an information resource, but also as a measure of being able to monitor what's happening to the person over time. And the idea is you buy one for each person you're supporting, and that acts as your sort of care plan and Bible all the way through their dementia. We've done some videos with the Down Syndrome Association in the UK. So this one is a sister's story. It's called Fighting for Andrew. It's a sister's story of fighting for what was excellent care. And this one, which is me again, talking about philosophy of care. Happy eating, talked about. And then this one is really nice. It's called Supporting Derek. So if anyone's coming to my session later on after lunch, you'll be seeing some of the video from Supporting Derek. That's a really nice pack to think about what you're doing with people. Okay, so I want to now move on to working with the person with Down syndrome and to their peers. And again, there hasn't been much information out there about how to work with people with Down syndrome. I don't know whether there's information that's specific to Canada, but when we certainly looked in the UK, there was only one booklet for people with Down syndrome about dementia, and I haven't bought it because it's horrific, and I should bring it because it is horrific. And I don't normally criticise other people's work. I normally bring it with me. I think I must have had If you open it up and it says dementia is a disease of the brain, and it shows someone with the head come up and their brain exposed, and I just think, what message does that give people with a learning disability about what happens when you've got dementia? Your brain's going to pop open, your head's going to pop open, and your brain's going to appear. So you have to be careful about the stuff you use. We've developed 3 booklets that have been published in the UK about different aspects of dementia and also about life as well. What we realised is that for a lot of people with learning disabilities, they really don't have the same life stages as you or I. And because they don't have a good understanding of age, they don't relate age to life stages. So we think about, I'm middle-aged, and it's because I've got a family and all the rest of it, and I'm getting older. But most people with learning disabilities, A, can't tell you how old they are, but B, even if they can, they don't really have a good understanding of what 50 means or what 30 means. It's just a number. It doesn't have that same connotation to you or I. So we were asked to do some support for a group of people with Down syndrome who had their second person in their group who was developing dementia. And the staff said to me, many years ago now, Karen, how do we explain dementia to people with learning disabilities? I thought, right, okay, that's a new one to me. And what we developed was, first of all, this booklet was called The Journey of Life. And what it does is it talks about the life stages for people. And what it's got, sorry, I keep hitting the microphone. So it's got an instruction booklet. And what it's got is it's got some simple words if you want to use them, but if not, staff can use them. But it's got some really quite nice line drawings that you can work with the groups of people with. And it's based on the premise of care, because it's the one thing that people with learning disabilities understand about. It's about care, because they're always the recipients of care. So we talk about babyhood being the time when you need the most care in your life. Okay? So you're a baby, you need someone to feed you, you need something to support you to sit up, you need something to support you to be moved around. And as you begin to grow, you can start doing things for yourself, but you still need lots and lots of care. And again, when we do it with individuals or groups, we tend to do it with great big collages and quizzes and those sorts of things. We then talk about childhood as being the time when you begin to need a little less care and start to do things for yourself. And I can tell you how long ago it is since we first ran this very first group before we wrote the book. Because my oldest daughter was 6. and she's now 26, so gosh, 20 years ago. And I brought my daughter into the group I was working with, and she was really glued because she said, I'm allowed to make a sandwich and I can get a cold drink, but I'm not allowed to use the kettle. I can't have a sharp knife, and I'm not allowed to cross the road on my own. So again, very practical things that people with learning disabilities, people with Down syndrome could relate to. So childhood is the time when we begin to need less care. Then we move to adulthood, and this is the time that on the whole people are the most independent, so they need the least amount of care for themselves. So that might mean things like doing your own cooking, doing your washing, going shopping, travelling independently, having fun, going to parties, going on holiday, having a partner, having the key to your own door. And again, so you can explore with people about what care they need and how much care they need. And then as people get older, they tend to need more care again. So again, thinking about that cycle. So you might need glasses for the first time or a hearing aid. You might need help up the steps. You might need a bit more of a supportive chair to sit in. And again, we're talking about their friends and family, about needing more care as they get older. Getting older might be a time when perhaps you can't live in the same place. So you might move to a different home, or that you might need to see the doctor more because you might have more physical health problems. And one of the problems with getting older is you might have one of those special illnesses of getting older called dementia, and that might mean that you need even more care more quickly, and you might actually need care right to the end of your life. And so this was a really good way of helping people understand. When I ran the original group, the second lady with dementia used to have a shared bedroom. We don't do that anymore, but this is 20 years ago. A shared bedroom with one of the ladies in the group. And the lady in the group said to us in the group, she said, I know about more care. She said, because some days, and we thought this lady could still dress herself, by the way, shows you how ignorant we were, because she always appeared dressed every morning. She said, I know about care, because some days she's all right, and I only have to give her the clothes in the right order. And other days she can't do much herself, and I have to dress her. Well, we didn't know, did we? And then one of the gentlemen piped up and said to me, I know about more care too, because I sit next to her in the day service. And you know, she don't drink properly. So every 5 minutes during lunch, I nudge her in the side and go, oi, drink. So then we went on to develop the other two booklets. This one's called About My Friend. And this is trying to teach people about dementia from the point of view of being a friend of someone with dementia. And we start it at mid-stage of dementia, because we work out that's probably the stage when most people, it's more obvious to the people that they live in. So we begin to talk about the things that your friend might do that might be a bit odd. So here he's going out in his underpants and his dressing gown, and here he's putting his shoes in the fridge. I have to tell you, my artist, was one of my clinical nurse specialists, drew me a whole set of drawings that I couldn't publish, including someone eating a bowl of daffodils. I said, I can't put that in the book. We talk about it as a time of getting older and people needing more help. We talk about it as being a time that perhaps your friend is doing things that aren't as friendly. So here he's a messy eater. And again, what must it be like if you're the friend of someone with dementia and you're the person always sitting next to them when there's food flying everywhere? Or maybe your friend is doing things that aren't very nice. Maybe they're pushing you, maybe they're tearful. And again, it's a really nice way of being able to explore with the person and with friends about what's going on. Your friend's going to need more help. Maybe your friend can't stay in the home because they need a lot more help. And eventually your friend's going to become much more poorly. Maybe they just sit in a chair a lot. Maybe they get to the end stage and go into their beds. And unfortunately, your friend is going to die, because we all die. But again, you can go to their funeral, wherever that is, and you can remember your friend. And again, it's quite a nice way of just having those conversations with the person and also with their friends. And then the third book, we wrote for more able people with learning disabilities. So maybe they've got a family member who's develops dementia, or maybe it's a word they've heard on the television. And so this one hasn't got any pictures because we decided to try and avoid all those half a brain showing and all those sorts of things. but it's just got some simple language. And actually, it's quite good to use with new staff as well sometimes, particularly staff who perhaps don't have good literacy skills, because it's actually written in a very simple way. So we talk about what's dementia, what happens when people get dementia, do the changes mean the person definitely has dementia, can you get better with dementia? So all the questions that you might have someone with a learning disability ask you, intellectual disability. What happens if it is dementia? Who's most likely to get it? And again, we have put people with Down syndrome, because if people are able to ask the question, then we will give them a truthful response. What should you do if you're worried that you've got it? And what should you do if you're worried about someone else who's got dementia? So hopefully that's quite a nice way of actually introducing dementia for people with learning disabilities. And actually this has been this booklet is now, we have something in England called Books on Prescription. So we have a whole scheme in England about books being on prescription. And I was really pleased that this is the only one for people with learning disabilities that is actually on the prescription list. So it's in libraries and GP surgeries now, which is lovely. And again, we talked about peers, so they're often the forgotten group. There has been a little bit of research about holding forums, about seeing what other people think about it. So Liz Forbat and Heather Wilkinson worked with a group of people, and they felt that dementia was negative on the people who didn't have dementia. They also felt that people with dementia got special privileges. So again, it's really important to be able to explain to people that actually it's not about special privileges, it's about just people need some more support. And we know that helping peers to understand dementia can reduce their distress and also make them more considerate and understanding of the changes to the person. And that can also help prevent placement breakdown. And interestingly, I went into one home quite a few years ago now, where in fact, it was the home manager who was causing the problems, not the other not the other people who lived there or the staff. And they were having real arguments about my particular lady with dementia and her chores, because she always wanted to do the washing up. And I thought, well, what's the problem with her always wanted to do the washing up? Oh, no, the home manager says, we have a rota. Right? So could we not adjust the rota so she just does the washing up for the time being? No. The other people in the house set the rota. Well, could you not just talk to the other people in the house and ask them to adjust the rota? No. So this went on for several months. In the end, I said, right, I'm stopping this now. I'm coming in to talk to the other people. No, you can't do it. I said, I can. And I did. And I sat down with the rest of the residents in the home, and I explained that the lady has an illness called dementia, and that it means that sometimes she prefers to do particular chores, and that sometimes it's easier to let her do those particular chores than have the arguments you're having now. And would it be possible to do something with the rota? And what do they all say? Sure. So we solved that overnight. But again, it wasn't the peers that was the problem, it was the manager. But again, getting in to talk to people is important. So again, we can use the books, we can use the videos, we can use all sorts of things to try and help explain to people who live with people with dementia, or go to the day opportunities, or work with people with dementia, about what it means to have dementia. And I think that's a really valuable way of using expertise and time. And I've talked about that. So what I want to do now is to really think about what needs to be in place in the system so that we get it right for people with learning disabilities, with Down syndrome and dementia. And I'm just going to go through a set of slides which I think, for me, tells me what needs to be there. And that's the list I'm going to go through. So first of all, you've got to start and make it happen. Often in services, everyone talks about it, but actually nobody gets together and makes it happen. And it doesn't matter where you are in the system, whether you're a professional, you're a service provider, you're a commissioner, you're a family member. Actually, you need to get people in a room and just get people to start talking and think about where do we need to go. Because it is about working together, it's about constantly developing and improving what you offer as a whole system, and then it's about measuring those outcomes. Are we doing the right thing to the right people in the right way? So let's think about what needs to be in place. Excuse me. First of all, I think that actually, in order to get this working, you need to have a dementia strategy. You need to have something that people sign up to, service providers, commissioners, day service providers, families, sign up to about what are you going to do for the people in your area. It needs to have an agreed action plan, and it needs to have some standards about what you want to expect. So you might need to think about which agencies are involved. And again, you might not get all the agencies around the table at the beginning, but if you start with some agencies and they see you doing good work, then hopefully other agencies will want to come on board with you. You need to think about whether you've also got a mainstream dementia strategy. And again, I don't know how it works here in British Columbia, but again, often the mainstream dementia strategies in the UK don't think about the needs of people with learning disabilities or intellectual disabilities. And so you might need to think about, is this an extra to it or an addendum to it or a completely separate document? You need to think about who signs it off. So who has the ultimate control? Where in the system do you have a place where that can be agreed? And again, that might be different in different areas. And then you need to think about, is it going to be resourced? And who's going to fund it? Is there going to be any new funding? If not, how are you going to manage within the funding that you've already got? How are you going to implement it and how are you going to monitor it? And what changes can you make? So the commissioners, what can they tell you? I'd like you to do differently. So is it about telling service providers, we like you to do this rather than that? How can we make it different? How can we get better care for people? I think every area needs to have a register or a database of people with Down syndrome, people with learning disabilities in particular, but which particularly identifies people with Down syndrome, so that it can be used to plan and deliver effective services. If you don't know the number of people that you're going to be caring for, how do you know the size of the problem that you're going to be working with? We know now the sorts of percentages at each age of people who might develop dementia. So if you know how many people you've got of each age band, you can then work out what sort of service provision you're going to need to meet those needs. But if you don't know how many people you've got, you're starting from such a low base. So again, it's quite a lot of work to start, it's quite a lot of work to keep up. You may have data issues about sharing information across different agencies, but all those need to be tackled so that you actually do know who you're actually dealing with in your local area. So is it comprehensive? I don't know whether it's similar here, but certainly we have quite a lot of movement of people across areas so that some people might not originate from a different area but are placed within your area because your services are better, or just because there are more services. So again, who funds those people? How's that going to work? How do you keep the database up to date so it's live, both from people who are new into the area, but also people who've died? So you actually try and keep them to monitor that. Do you need to decide what information you're going to collect, how detailed you want it? Obviously, the more information you collect, the less likely you are to manage to collect it. So you need to think about what the basics are. How easy is it going to be to keep it up to date? And for me, we've always kept a deaths database, and people go, you're really ghoulish, Karen. But actually, it's really important to know when people die, what they die of, where they die, and what could have been done better for those people. So again, we've now recently added to our deaths database place of death. And it's really interesting when you start to really drill down. You know, we've got several people who've died in the back of an ambulance being shunted backwards and forwards between their care provider and the hospital and back again. So you do get that sort of data. And it really is, so most of our people who've died over the last 20 years do die of related to dementia, particularly around pneumonia or aspiration pneumonia, respiratory problems. But interestingly, we've had 4 people die of liver-related disease. And again, we do know that liver-related problems are very common in people with Down syndrome, and that they're not drinkers. It's not because they're taking alcohol. We've had a couple of people die of cancer, but very few compared to what you'd expect from the general population. And we've had some horrific deaths that we've had to incorporate. So we had one gentleman who died of scalding after being put into a hot bath. But it's important to have those so that you know what's going on. Is there a good care pathway? So is there an agreement for people who develop or at risk of developing dementia, a care pathway that identifies what happens as part of the assessment process, diagnosis, and what treatment and support they'll get. And who then delivers that? So is that all delivered within intellectual disability services? How much of that is delivered within other services? So does it involve older people services for us? Does it involve your neurologist? Does it involve general physicians? Does it involve advocacy services? So again, trying to write through what your care pathway looks like and getting a sign up from all the relevant agencies. It doesn't need to be complex. It can be quite simple. In fact, the simpler ones are the easiest ones to manage. I've certainly seen people who've put together care pathways that sort of cross 20 pages, and I think you're never going to actually implement that. It's just far too complicated. Let's get the main bits right, and then we can add bits on as we go along. Have we got good multidisciplinary working? So do people who develop or are at risk of developing dementia offer the assessments, the diagnosis and the support from a full range of dedicated and trained and skilled professionals? Do they have good access to the specialist assessments might need? For example, if someone develops epilepsy, are they getting to see the neurologist? So you need to be able to identify who your key professionals are. You need to think about how you keep them up to date, because this is a changing part of working. So how do you keep your professionals up to date so they keep other people up to date? We, in our services, have a monthly dementia practice group. So our key professionals get together once a month, and we use it for continuing professional development, but also to discuss the people with Alzheimer's disease who we have in common, so we can think about the types of care we're offering. Do you work with the GPs? We do work through what's called directly enhanced training and our GP with special interest to try and get GPs on board. It's not often easy to get our GPs on board. Some are better than others. We have a health group that works to try and identify gaps in the service. And we also work very closely with our acute nurse liaison staff who work directly into the local acute general hospitals to support people when they go into hospital. So again, making sure that they train general hospital staff about the needs of people with Down syndrome and dementia. Do people have easy access to a really good assessment and diagnostic services according to an agreed protocol? And again, this takes a lot of work to get into place, but it's really important because you'll need to think about a number of things. So first of all, you need to think about providing reactive screening. So if someone is presenting with changes, what are you going to do and how are you then going to ongoingly monitor that person? In order to do that, I think you need a baseline assessment for every adult with Down syndrome while they are healthy. Because people with Down syndrome are not a homogeneous group, because everybody is an individual, they've all got their own individual cognitive abilities and deficits, you need to have knowledge of what they were good at the peak of their potential. And certainly in the UK, and I think probably fairly much in North America now, it's accepted that the peak of their potential is probably around the age of 30. If you do the baseline assessment younger, people are still developing. And so you're not getting to the top of their abilities. If you leave it much later, they're already maybe beginning to show some of those really prodromal early signs that might end up as dementia. So you need to have something on record that you can use in the future. Now, the whole issue of whether you undertake prospective screening is one that is still out for juries, really. It's hugely time resourceful and costly, depending on how many adults you've got with Down syndrome. Us in Surrey, with 500 adults with Down syndrome, we couldn't possibly do prospective screening to any agreed time frames without a huge increase in resources. And I'm not sure whether it's ethically right to do that. I think you need well-trained staff and well-trained families who know the early signs of dementia and who can refer in right early on to actually have a repeat assessment, a reactive screening. I'm not so sure about the prospective screening yet. And certainly we don't recommend prospective screening for people with intellectual disabilities without Down syndrome. So why do baseline assessments? Well, as we know, there isn't a definitive test for dementia. You can't actually go out and have a blood test or anything else that shows you've got dementia. So you need that good clinical history, you need evidence of a change in function from a point in time, and you need to be able to exclude all those other things that we talked about yesterday that may mimic dementia. Often by the time someone is referred, often considerable deterioration may have already happened. So trying to establish pre-morbid functioning for someone that you've just met can be quite difficult if you haven't got a baseline. And therefore it gives you longitudinal data that you can then compare people to over time. So it really helps you to understand what's going on. And remember that an assessment is only about looking at change. It doesn't necessarily at that stage give you the reason for the change. You're going to have to do a lot more digging. So you have an assessment at time 1, you do the assessment at time 2, you look at the qualitative and the quantitative data and say, yes, this is different. And then you start going, okay, what's that caused by? Okay, and so you have to do all the exclusion things we talked about yesterday before you'd even begin to think it was dementia. But it allows you to actually begin to start that process. And as I said, prospective screening, difficult still to say whether it's completely justified, particularly around cost and intrusion. When you are thinking about assessments, then you need to think about the appropriateness and the choice of your assessments. I think people sometimes get carried away. They think of the word assessment and I just had another one, and I had another one, and I had another one. And people write to me and say, can you look at my assessment battery, Karen, and see what you think? And they send me these pages and pages and pages of tests they're going to do. And I look at them and think, this is for somebody with intellectual disabilities. Their concentration span, if we're on a good day, will be the maximum of half an hour to 45 minutes. This lot is going to take you 6, 7, 8 hours. What extra information is it going to provide to you? So I spend a lot of time going, really? Do you need to? What's going to happen? What are you going to use it for? So you need to think about the suitability of your test battery. It's got to be suitable as the dementia progresses. If people are already scoring very low on it, you're not going to be able to see the change in time as people's needs change downwards. So you've got to have a set of tests that has good floor and ceiling effects, and it's got to be reliable and valid. You need to think about collecting other information, so documentation, video perhaps, and also the longevity of your assessment choice, because you can't chop and change. Once you've started with an assessment battery, you've got to stick to it. So you've got to be happy that it's going to work over a long period of time. And then you need to think about how you're going to monitor people once you suspect people have got dementia. You need to think about how you share information with the person. So is there a protocol or training for staff on how you do that? Do you provide easy read reports? We do. And we have pictures like you can see there below. And the timeliness of the diagnosis. Again, I tend to err on the side of caution because I would never like to make a mistake. And I'd rather not diagnose but say I think it might be, or use words like that rather than be definitive, because sometimes you prove wrong. Sometimes it is other things that you just didn't know about at the time or that come out of the woodwork later. We need to make sure that the system develops really good person-centred care according to good person-centred principles. And this is all the things that we talked about yesterday. So I'm not going to go into it in any detail, but it's about having a model of understanding dementia, moving away from this idea that dementia is just a catalogue of horrors. There are lots and lots of really positive stuff we can do to support people with dementia, but it has to be about individualised care planning, focusing on positivity and quality of life, making sure it's consistent. And then I think probably the hardest bit is getting this flexibility. And the one that always causes us the most problem is transport. Because people go, well, you can only go to the day service if you can get onto the transport at 8:30 in the morning. Yeah, but I can't get him out of bed at 8:30 in the morning. Well, why can't the transport come later? Oh, no. So we need to really think about, if we are going to offer really good person-centred care, then the day activities need to be person-centred, and the transport and the care to support those needs to be person-centred. And how do we get people to move around safely? We need to make sure that people have access to the full range of interventions, both medical, psychological, therapeutic and social interventions. And again, We talked a lot about those yesterday. So is there an agreed protocol for the use of medications, particularly the anti-dementia, the acetylcholinesterase inhibitors? Is there access to the full range of different professionals and the equipment they provide? How easy is it to get that equipment? Can services recognise and provide the support that's needed? Do people really understand the impact of dementia on short-term and rollback memory? And are we providing failure-free activities to people? Are we making sure that every place that somebody with dementia goes is dementia-friendly and able to meet people's changing needs? Do you know how many of your services that you have out there are dementia-enabled? Do you know which of the homes, which of the day services, which of the community resources actually help people rather than inhibit people? Have you got the right sort of equipment in the right place at the right time? And then end-of-life care. We need to recognise that dementia is a terminal illness. You don't die of the dementia, but you do die of causes related to dementia, and as I said earlier, primarily around breathing difficulties and pneumonia. In the UK, we have an end-of-life strategy, which starts normally here at step one, we've changed it, which is about discussion of end-of-life approaches. This needs to happen much, much earlier for people with dementia. You can't wait till they've got dementia to start having these discussions with people, because those discussions won't be meaningful. So we need to think much earlier on about making arrangements for the future, and then helping staff to recognise illnesses that might tell you that someone is reaching the end of their life. And then you can go through all the other stages of the dementia. How do you link to local palliative care services? What specific training and information do we need to give families, peers, staff to support people? How can we make staff confident that they can do the work? Because it is very traumatic to support people through to the end of their life. For a lot of young staff, it may be the first and only time they've actually seen somebody die, and they may be quite worried that they might be the only person on duty when that person does reach the end of their life. Do we give really good emotional support and training for staff and carers through that process and help them think about what they need? And do we provide additional staff as required? This idea, waking night staff for us in the UK is the biggest bugbear because it's so expensive and often causes the most difficulties about keeping placements ongoing. And have we thought about where do people want to die? Dying in a hospital for most people should not be the preferred place of death. What we want to do is try and get people to die within their own bed. But again, that means the systems need to be in place, for example, to provide oxygen maybe within a care home that always causes issues, to have the right medication, so maybe you need a syringe driver. So do your local district nurses, or whatever they're called over here, don't know what they're called over here. Thank you, community health nurses, able to come in and support people in their own home to get the medication and the support that they need. We've developed 3 booklets around good deaths. One is about for people with learning disabilities and helping them to understand about end-of-life care. One is for staff working with people with learning disabilities, and one is for staff working in general hospital settings or acute settings about working with people with learning disabilities. So different aspects. And again, I can give you the references to how you get hold of those if you're interested. What am I doing for time? Nearly. And then once you've got all that in place, do you have a really good system of care management and review? And again, I don't know how it works here in British Columbia, but do people have a named person who oversees their care? We would call them a care manager in England. Are there regular care reviews? Because this is a changing condition. What is right one day will not be right 2 weeks later, 3 weeks later, a month later, a year later. So you need to be able to adapt the care that's provided as the dementia progresses. Is there access to flexible funding to meet changing needs without delay? It's no good having to wait months and months to get extra money if you need an extra member of staff or you need a new wheelchair or whatever. Are outcomes monitored about people's quality of life? Are staffing levels increased? And then the whole issue of moving, which I'm going to look at now. And I think this probably is the most emotive part of anything we ever talk about, which is where people should live. If you go back to the principles, the laws of dementia, if you go back to everything I've talked about over the last 3 sessions, I think hopefully what you'll have learnt is that consistency is absolute the key to providing the work that we do. Consistency of place, consistency of people, consistency of support. So if you have to move somebody, then actually that's going to disrupt everything that person knows in their life. So we need to think about and be really much, much better at advanced planning. You will know, if you've got a good database, if you've got a good register, you'll know how many people you've got in each age group. You'll know where they're living. You'll know whether that place is suitable for them if they're going on to develop dementia. We now know that up to 80% of people with Down syndrome will develop Alzheimer's disease as they get to 60. So we need to do much better forward planning. We need to make sure that we support our staff. We need to make sure we get additional staff as needed. We need to make sure that the environment is friendly. We need to make sure we've got the right model of support. But if you haven't got a home that is suitable, and certainly a lot of people in the UK, when they moved out of long-stay hospitals, when we moved into ordinary houses in ordinary streets with only upstairs bedrooms and bathrooms, they are not going to be suitable in the long term for people. So if a move is necessary, where do you move people to and when? This is taken from Matt Janicki and Arthur Dalton, who talked about ageing in place. We decided from when they're working in New York and the East Coast, we decided to change it in our guidance to dying in place, because actually it's not just about ageing in place, it's actually dying in the place that you prefer. And what he talked about is that there should be 3 options. First of all, that the preferred option is that people stay where they are as long as obviously it's suitable, with all the appropriate supports put in to meet their needs. And that's clearly got to be the best for people, because everything is familiar in their long-term memory. If you've got to move people, then all the research says that moving should be to a better specialist learning disability provider that can meet people's needs in the long term. And then there's a lot of evidence that moving people out of learning disability services to services for older people or generic services actually has very poor outcomes for people with Down syndrome and dementia. And so that should be our very last, if ever, resort. So sometimes we can't keep people in their existing home. Sometimes the design of the building is just completely inappropriate and you can't do anything about it. If you can't put an extension on, you can't make a downstairs bathroom, downstairs bedroom. Sometimes it's about people being cared for by older family members who themselves can't care anymore, and therefore you have to move people out. If you do that, you need to make sure that risk assessments take place, to make sure that the environment is safe. And sometimes it may just be that the staff reach a tipping point where there's just insurmountable problems with the placement. So, and then finally, the one that we need to fight out most is about funding. Oh, we can't place them there because it's too expensive. Actually, this is somebody's life. I don't care how much it costs. This is about putting value on someone with a learning disability. Deciding when to move is always a very difficult decision. Clearly, the environment would be less important if you could move people with everyone else they know. So if you could up sticks from an inappropriate home and move all the people and their staff to a new provision, then actually that's going to be the best you can do. That rarely happens. We tend to pick off the poor person with dementia and move them to somewhere new with staff they don't know, other people they don't know, and an environment they don't know, and then wonder why they become really agitated, really confused, and die very quickly. If you move, once the move is inevitable, then you need to think about when you're going to do it. There isn't a good time. In my experience, if you move people in early mid-stage, you increase their rate of deterioration. And if you move people in late stage, you increase the risk of early death. What we do know is that multiple moves should always be avoided. If you're going to move someone, it has to be a one and final move. So you have to be really, really clear that move is correct for that person. It's not an easy decision to make. Some research that Diana Kerr did a few years ago, she followed up people at all different stages of dementia when they were moved, and all but one had died within 8 to 12 weeks of the move. Okay? We've certainly had people who are moved. I had one person, in fact, we were in the middle of assessing, and the care manager decided to move him on the Wednesday, and I got my assistant to phone up on the Friday to make an appointment to carry on with the assessment, to be told he'd died of a heart attack the previous evening. And again, I'm sure that the stress of the move to somewhere completely unfamiliar precipitated his death. So again, what you need to consider is all the things we've talked about. And if the person does need to move, then it must be close to their existing home so that you can maintain their links with all their existing day and leisure services. Because if you move them far away, they're going to lose all that as well, and that's going to completely leave them bereft. So you really need to think really carefully about your advanced planning to get people in the right place earlier. So what I'd like to do to finish is just do a summary of what I think good looks like. So for me, good means that we all have a shared vision of what we want for people with Down syndrome and dementia. It means that all our care is delivered in a person-centred way, that it's individualised, that we know and can identify the cohort of people at most at risk. So in this case, it will be people with Down syndrome at the age that when they're most at risk. We need to be able to offer timely and appropriate baseline and follow-up assessments and correct diagnoses. So we need not to be rushed into diagnoses, but make them considered and carefully. We need to offer good team-based training and support to staff to ensure that we continue to have a capable workforce. We need to value our workforce. We need to support them. They're a huge resource. We invest in them well, they'll stay. If we don't, they'll go. And that affects the care we provide to people. We need to make sure that we offer really good ongoing support to families, carers and peers that's targeted to meet their individual needs. We need to make sure that people's health needs are met promptly and that we don't allow diagnostic overshadowing, so that everything they have is put down to the dementia. We need to make sure that we treat people accordingly. We need to ensure that our environments are dementia-friendly and dementia-enabled. We need to make sure we offer the whole range of multidisciplinary interventions, and we need to make sure it's all about enhancing quality of life, because that's the most important. We need to work with all agencies to make sure people are kept within familiar settings, with appropriate staff and care that is regularly reviewed. We need to make sure that end-of-life care is discussed as appropriate and that people are cared for within their own home, wherever possible. And lastly, that we need to make sure their quality of life is measured and enhanced throughout the dementia. It sounds a lot. It is feasible. When we do it well, we do it really well. And when we do it badly, it's appalling and people suffer. So I hope that this has given you some thoughts and ideas about how we can look at system-wide at improving the care that we provide to a very, very vulnerable group of people in our society, but who give us so much joy, so much pleasure, and are just absolutely wonderful to work with. Thank you very much.